All right.
Hello and welcome to today's webinar, everyone. I am Trevor, the Communications Manager for the Canadian Cancer Survivor Network. Thank you, everyone, for attending today's webinar. This is our first of our fall series for 2023. Sorry, our multiple of fall series for 2023. If you're new to our webinar series, a little background on our group. CCSN is an organization working with cancer patients and survivors to learn about the complexity of our health system, connect with others to plan action, and act on those plans to create better outcomes and healthy survivorship. Please visit our website to find plenty of information like news and events, and of course, our webinar series. Now, this webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We'll add a quick Q&A session at the end, but if you would like, put your questions into the questions function here on GoToWebinar. You can find that on the side of your screen. And now to introduce our presenter. Don Husereau is an adjunct professor of medicine at the University of Ottawa. He does freelance healthcare research and works with private and public sector life sciences organizations to help them understand the value of health technology and its implications for health and innovation policy. And now, without further ado, I'd like to hand it over to Mr. Husereau for his talk, Access to Genomic Testing in Canada, Are Healthcare Systems Prepared for Future Testing?
Okay, and thank you very much for that kind introduction. So yes, I am Don Husereau. Today I'm going to talk about some work that I have done over the past year or so on a state of readiness progress report looking at access to genomic or genome-based testing or genomic testing in Canada. Just to let you know, I do work for both private and public life science organizations. I have been involved and sat on, for example, PERC, the Committee to Evaluate Drugs, Oncology Drugs in Canada, but I've also worked extensively and continue to work extensively with pharmaceutical companies, diagnostic companies. This work that I'm going to present to you actually was supported by a consortium of both drug and diagnostic companies, including the ones that are listed at the bottom. So I'd like to talk to you about what the issue is. I'm aware of this audience is the Canadian Cancer Survivor Network, so certainly you're going to be interested in oncology, but I want to talk about potentially more broadly than oncology, talk about how I approached assessing Canada's progress, give you some of the findings, and talk about some priority actions as well. So before we proceed, it's important, I think, for people to know, I mean, one of the things that I do is look at technology proposals quite often, typically typically with drugs. And we all know that drugs are becoming a little more complex in terms of the requirement for example, IV infusion clinics, or maybe subcutaneous administration. We have now gene therapies and cell therapies that even have more active components. We typically call these types of context-dependent interventions complex interventions, and genetic testing, just as a starting point, people need to know it's not something where you just need to buy a machine and do a test. I think we all saw with COVID, for example, it's not a simple matter of buying the test or using the test. The test has to be used under certain circumstances and in a certain way, and there's a certain amount of education that's required and a certain amount of timing. And so this is no different with genetic testing. It requires a whole bunch of moving parts, including people, education, and the like. The other thing you just need to know in terms of terms, I'm going to use the word genetic testing and genomic testing kind of interchangeably. I might refer to it as genomic medicine when we're applying genetic testing. Personalized medicine, precision medicine, that's often used interchangeably. I'm not using that term because I do think when we look at the person, we're looking at more than just their genes. We're looking at their lifestyles. We're looking at other factors. And so I think it's maybe a bit misleading just to think of genetic testing as personalized medicine. The other thing I want to touch on is that when we are talking about genetic testing, we need to think about the fact that these tests serve many purposes and can serve multiple purposes, even for an individual cancer patient. So certainly they can help us diagnose a person who has a disease, and they can be very effective at diagnosing things like rare disease, for example, where you may have only one gene mutation that needs to be detected. But they're often used in cancer. Cancer is a genetic disease. They're also prognostic tests that help us understand what the future of the patient is going to be, what the future of a patient with a disease is going to be. And that actually can help physicians make choices about therapy, for example, whether they want to use therapy that might be more aggressive versus not. Genetic tests are going to be and are increasingly used in prediction and monitoring. So we use them, they both can predict how well a person might well respond to a drug, but we may also use them to monitor ongoing response to a drug to see how the disease is proceeding at a molecular level. And this is becoming more important in some diseases like colorectal cancer, for example. And finally, and something that is quite often overlooked, is if we actually use a test, we learn more about a disease. We can learn a lot more about disease, and we can also qualify people for investigation or research into disease. And that could be a clinical trial. And in cancer, where new cancer therapies are quite often successful in a trial investigation, we're actually offering a patient an opportunity for real benefits by actually providing new tests to them. So I mentioned we do use testing primarily in oncology because oncology is ostensibly a genetic disease. But what we're going to see, and we also use genetic testing for things like prenatal screening, rare disease diagnoses, neonatal care. But what we're going to see is more and more of these tests are going to be used for qualifying people for cell and gene therapy, and then into broader medical conditions. So we're starting to see applications in psychiatry, ophthalmologic disease, cardiovascular disease, and the like. And so this is just a graph looking at how pharmacogenomic testing has been associated with the use of drugs over time, and it just continues to go up. I see a lot of technology proposals. I can tell you that most commercial technology is cost add, which is why we have all of this fuss about costs and negotiating prices and budget impacts. However, testing actually is one of the few technologies in healthcare that actually can lower costs. It can actually create a return. This is an example that came out of Australia using something called whole exome sequencing as a early routine test for infants who are suspected to have disease. So then rather than putting them through a ringer of several diagnostic tests and imaging and back and forth and referral, this study in real time was able to show that for every 40 children suspected to have some sort of disorder, they were able to get 25 diagnoses versus 7 using a traditional pathway. So they were able to get a higher yield in a shorter amount of time, and individually for each patient, we're able to save $2,000 just in terms of healthcare resource use. And that's and if you look here, I mean, the cost of the tests were not insignificant. $80,000 at the time to run the test for these 40 patients, but still they saw savings. That is not to say that all tests result in savings, but certainly do have potential to do so for the healthcare system, and more importantly, shortening up the journey for the patient and improving diagnosis. So testing has all this impact. It can help us, of course, it can help us achieve better health outcomes. We can even test in certain cases to see if you might be harmed from therapy. There are applications of pharmacogenomic testing that can do that. Obviously, when it's for targeted treatment, we might see improved survival, improved quality of life, as we might be able to avoid things like chemotherapy. But these are not all the things that matter. It's not all inequality. We care about things like patient experiences, how much referral and running around they have to do. The care providers care about that too. They're not interested in having patients bounce back and forth between providers and between healthcare services. Sorry. And so important to improve. This is part of the quadruple aim, is improving care, improving experiences. But it also, because we can actually learn more about disease, we actually have opportunities to capitalize from that. We can aid scientific discovery. We can increase the amount of clinical trial enrollment that we have, which is, again, pretty important for particularly for some kinds of patients who may really benefit from that. It might provide also investment opportunities. So really, I think from a government policy perspective, getting testing in place so that you are ready to take on testing is an important consideration. So this is in the report, and I'm going to point you to the report very quickly. But when we talk about testing being cost effective or even reducing costs, this isn't just simply when we're using it as for the purpose of treatment, for example, some sort of biomarker. This can be across the board in terms of diagnosis, prognosis. There are multiple examples across all of its applications where it leads to a better use of healthcare resources. So why did I undertake a state of readiness progress report? Well, the idea was someone needed to capture how we're doing in Canada so that we could objectively communicate that back to policymakers. The idea of a progress report is that it's something that's easy to respond to. We give a kind of rating of care. I'm going to tell you about how I did that. And so what we want to do is what we wanted to do was look at what conditions were needed and then tell policymakers what needs to be done and provide them a future direction. There's also future direction for research and the research community as well. Obviously, bodies like Genome Canada really do have a stake in making sure that we're doing appropriate types of research in this area. So my approach was first, I did a lot of information gathering. We're not going to change policy through simple opinion. We have to, dig further. So, this was literature search. This was interviewing experts in the field. This was working with people who are embedded within various healthcare systems. The focus of this report was on BC, Alberta, Ontario, Quebec, and Nova Scotia, just because these are the largest provinces or the ones that are playing a larger role in this area. So the starting point was, let's work with both these national experts and international experts to create and validate a list of good conditions. I'll talk to you about what those conditions are. So in other words, let's come up with an agreed upon list of what it means to be ready for the future state of genomic testing, well, the current state of genomic testing. I mean, we have to be ready today. Then let's go back and we'll look to see how individual provinces are doing, focusing the entire time on this quadruple aim, on the humanistic, organizational, economic aspects of testing. And then ultimately to communicate this. And that's what I'm doing here today, is I want people to be aware of this. And I'm going to give you some information about exciting opportunities to be engaged with this as well shortly. So as I said, I did talk to experts across Canada and internationally. And this is the progress report that was developed. It's a 74-page report. However, it does have an executive summary, and there are communication materials that are associated with the report. If you click on here, you will get to or if you scan this code, you will get to a website, which is access to genomictesting.ca. Now, this website was actually set up ostensibly to look at patient views of this, and so this is a consortium of patients supported by the sponsors of my research, who are interested in motivating change in Canada. So the State of Readiness report is there, but you'll also find some other information related to patient involvement with motivating change in Canada. And certainly, if you're part of a patient group or a patient network and you're not already involved, please reach out to me, and certainly we can get you further involved. We're having more and more patient groups interested in this all the time. So the conditions for readiness was published actually a year ago from the report. So like I said, I worked with national and international experts, and through an extensive look at the literature, came down with what we felt were a list of conditions. This is a link to a peer-reviewed publication of the report. However, I will go through these conditions with you now. We put them into three different buckets. So the first bucket of conditions we called the infrastructure conditions. And we looked at what is the problem that we're trying to change. And so within every province, what we're concerned about is inconsistent delivery of testing, or testing that is delivered depending on where you live. And so what is one of the things that we can do to resolve that problem? Well, the first thing that we can do is make sure that the left hand is talking to the right hand. So a necessary condition, and something that we saw in terms of a good practice, is communities of practice, having the right people together to coordinate and to be able to coordinate and communicate what is needed across the province. You see, in testing, this isn't just a matter of laboratory leaders getting together and talking about how they're doing things, because testing also relies on so many other people. There are so many other allied and healthcare providers that require testing. And most service delivery today, if you're involved with any kind of healthcare transaction or in the system, you're going to be tested at some point, and genomic testing is increasingly going to come up. So we do need to have this. We're also concerned about unsustainable care delivery. We need to have these tests are not like old-fashioned tests, the things that you're used to getting if you go to a community-based lab, what they call clinical biochemical tests, things like cholesterol. These tests require special machines, special human resources, technologists, pathologists, and the like. So we have to plan beyond just simply planning for the resources required to deliver the tests. We want to also avoid duplication, and we want to have high quality testing. Genetic testing is ostensibly an information rich type of testing. And anytime we're looking at genetic information, we have to think about informational needs. It's a lot of to think about, and so we need linked information systems in order to deliver this well. We do give examples in the report of good practices. For example, in the UK, they did allocate £4 billion over £4 billion over a 5-year period, just to invest in the digital infrastructure that's required for testing, for genetic testing. And we do see numerous reports, sometimes ad hoc, sometimes more systematic, about the need for genetic counselor, medical geneticists, and other human resources, including technologists, lab assistants, and the like that are required, bioinformaticians that are required for carrying out genetic testing. We do have a shortage, and that is becoming increasingly apparent. We looked at a second bucket of conditions. We call them healthcare environment conditions. One of the challenges with testing is it's not like a drug where you can just add, oh, here's a new drug, we'll put it on a formulary, and as each new drug comes along, we add it to the formulary. Testing requires you to be a little forward-looking. It takes a long time to actually upscale and implement a test. It can take months. And typically laboratory leaders are thinking maybe a year out to get a test really up and running. So we do have to think about then the future, and we have to think about the future of testing when we're adopting this. We can't just sort of wait for proposals to come along, otherwise it's too late. And with health technology, it's always too early until it's too late. We also do have to think, I said, if testing is also useful for scientific discovery and enrolling people in clinical trials, we have to think about the future that way. So there has to be some thought about the tests that we need for today, but the tests that we need for tomorrow. And that's very unique to this area of technology. We have to think about wait times and whether we can sustain testing. So we have to think about how we're going to finance testing. If we use old financial models for testing and we apply them to this type of testing, we're going to run out of cash pretty soon, because there are more resources in terms of human resources required to support this type of testing. We have to think about error and quality of care. I mentioned before about the COVID test. The COVID test is completely useless if a person is not educated about when to use it, how to use it. Well, it's the same with this type of testing. So we need to see patient education. We need to see primary care provider education. We need to see oncologist education and the like, and specialists, so that everybody is in tune. That means that provinces that are delivering this type of care need to think about educational strategies that are going to be all-encompassing, so that we're approaching this type of testing appropriately. And then with genetic information, we do have to think about negligence, liability. We have to think about substandard care. We have to think about regulating the labs and the services that deliver this. And we also have to think about what we do with information, who gets to see it, and the like. I feel like I skipped over one bucket. This is the third bucket of conditions we called operational conditions. These were, if you're actually going to deliver these tests, what do you need? You can't have testing coming in from everywhere. You have to have a way of managing what tests to consider and how you bring them in. So a single entry or exit point for testing is important. You can't, not all tests are valuable. Some of them, as I said, reduce costs. Some of them, under the wrong circumstance, I mean, a test that doesn't actually deliver information to a specialist when they need it is not valuable at all. So we have to have some kind of evaluative function to make sure that we are delivering high value care. And there may be situations where for a certain test, there may be various platforms or different ways to deliver it, but there might be a more valuable way to deliver that. So we have to think about value when we're thinking about testing. We have to coordinate care, and we don't live in a day and age. These are still big, expensive investments. We don't live in a day and age where we have little machines that can be on everybody's desk that deliver perfect results. So we do have to think about coordination. Where do the test samples go? How can they get back and forth in time to make a difference to patients and to make a difference or to scientific discovery or whatever we are doing with that test information? And ultimately, we can have all this set up, and then care providers and patients don't know where and how to actually get tests. And so we need to have tools for awareness and navigating people, as we do with any kind of complex healthcare service. So how did Canada do? Well, the conclusion of the report is that Canada was partially ready. And it depends on where you look. What we found was, in the darker color here, Alberta and Quebec were a little further ahead, and for various reasons that I'll get into. and some other provinces a little further behind, including Ontario, BC, Nova Scotia. Again, we didn't look at every province. Some provinces that are very small have to often outsource a lot of these tests anyway to their neighboring provinces or to out of country. We wanted to look at the major provinces just to get a sense of where Canada was going. One of the things that we noted, need for linked information systems and data integration. Of course, that's a bigger concern in healthcare in general, but it's particularly important in testing. Even if we could just link laboratory information services, that's a really important thing to do in this realm. We found the need, the application and use of evaluative processes. Typically when we're evaluating things for the purpose of reimbursement or delivery, we're using health technology assessment models. Some of them in Canada are very antiquated, taking years sometimes to deliver a recommendation, not really responding according to principles of HTA. There are actually principles of HTA that say HTA has to be fit for purpose. It has to, if the decision has to be made quickly, the HTA process needs to find a way to also evaluate quickly. HTA processes also can't be in an ivory tower. They can't be not engaging the broader community of patients, care providers, commercial innovators, and what you find is, well, I mean, this is endemic to Canada. There is still ostensibly a large lack of engagement among HTA bodies that are doing this work. We did find in some cases a real dearth of navigational tools for care providers. So care providers said, yeah, I'm aware that this test is something that's available for my patient. I'm not exactly sure how to get it or where, or it's very complicated to do that. And almost no provinces had dedicated funding to actually onboard a test or develop a test behind the scenes. So only the province of Quebec currently, sorry about the slides, only the province of Quebec currently actually had dedicated funding to facilitate the development of tests, and that's only a recent development. So the money has to come from somewhere. So yes, a challenge. And then finally, just beyond the HTA engagement, just broader engagement in general, testing has got such widespread implications for researchers, IT professionals, genome scientists, genetic counselors, and the like, that it's not something that you can just simply make decisions about in a closed room. You really do have to engage broadly. And testing for patients is going to have different meanings for different patients under different circumstances. And the only way you can discover that is through engagement. We created this fancy infographics to try to depict how these conditions, each of these colored areas is a either healthcare environment, operations, infrastructure. So this is the 3 infrastructure conditions, 4 operations conditions, 4 healthcare environment conditions. We left data privacy out of here because it's sort of covered under a federal program, so it's not jurisdiction specific. And these are the grades that I came up with. I call them readiness grades. So you see, for example, and for some reason, and I'm sorry, I realize now Alberta is out of this. Alberta received, I think, a grade of a B+. Alberta has a lot of their act together, so there was no places in the Alberta diagram of an empty color. The empty color means we have a long ways to go, whereas a dark color is meant to be you've fulfilled that condition. So in Alberta, we saw Alberta had created an organization years ago called Alberta Precision Laboratories. So it provides a lot of the coordination, a single entry point. It has a finance model. It is engaged with some level of resource planning. And so it has, through creating that organization, it's created a lot of the necessary conditions. And beyond that, it actually has linked laboratory information systems. So they've got our highest mark, whereas the lowest mark was given to Ontario. Ontario is just getting their act together on this. They created a program called the Provincial Genetics Program. They don't have a cross-provincial education strategy yet, but they promised to create one. Ontario has many evaluative functions for testing, including the OGAC process. They have a process that informs CCO. They have, and they're developing a new process. So there's many kind of chefs in the kitchen, but not a single kind of evaluative function. So many people using different frameworks to decide how and when to test. There is no single entry point for innovation. Testing comes in from many places. Ontario does not have linked information systems because it is very decentralized, and there are no kind of awareness and care navigation tools. There is now a publicly available formulary of tests that are available for cancer care, but beyond that, and it tells you kind of the hospitals that those are delivered at, but beyond that, I think you have to be kind of inside the system to understand how and where to get testing. They're working on a more coordinated service model. They are actually funding tests that are innovative, so they are future looking in terms of testing, and they do have some level of regulation of laboratories to ensure quality, and they're starting to do these things through this new program. So this, maybe years from now, this mark will change, but for now, they're still kind of just getting their act together. On the flip side of that, we have a province like Quebec, who also created a single service organization through their ministry called the DBBM, and has an evaluative function through INES. They actually do have a full finance model, including the development of tests with some level of education, coordination of service, and the like. And this is just a further expansion. What we did is once we created these, we have takeaways, and we have some specific recommendations for each province, which I'm not going to go into during this talk. The short form of this report was also together with a number of the laboratory leaders and international experts. We created a short form of this report, which is peer reviewed and was published in June of this year, so that people can get the short takeaways about how is Canada doing and what do the provinces need to do. So I'm going to reach the end here. I think the end of the day, how are we doing? Well, our major healthcare regions are moving forward. That's good news, at different rates and different paces. Some of them have more daunting challenges. For example, creating linked information systems. I think we've all heard anything to do with IT, or anybody who's in any organization has anything to do with IT knows it's a big deal. It's not that easy, and it can't be solved overnight. So some provinces are dealing with that, like Ontario and BC. Other provinces are much further ahead. They've created a lot of the organization required to deliver this type of testing service. But we can't sort of say all provinces are alike. And that, we don't get into the report about cross-provincial equity, which of course is a bigger concern. Are all Canadians being treated the same way, regardless of where they are? I would say it's probably not the case. We're still in an era where different provinces are responsible for their laboratory service delivery, and they're in different states of progress. There are many challenges that need to be responded to, and I think this happens anytime we have a new technology happen. When we have new types of diagnostic imaging, we have to start thinking about MRIs and PETs and how we're going to deliver that. It happens when we had proton beam therapy. It'll happen again. So we always have this challenge. We do have this new federal funding for rare disease. I think that does create a very strong argument to help create infrastructure for genomic testing. Of course, genomic testing is going to be important for rare disease, but you don't want to just create it for rare. You want to create it for everyone. You have to create this infrastructure for everyone. The same way we create hospitals and other healthcare services for everyone. We want to benefit we're going to end up benefiting people with rare disease, but we could, as an offshoot, end up benefiting others as well. So I will stop there. There was a lot of information. I have, if you want briefing material, I have short briefs and executive summaries that are on the Resilient Healthcare Coalition website. Here, there is the peer-reviewed article that I discussed here, and today's slides actually are available here. And you can always reach out to me by email. You can always send me a text or give me a call, and I'll stop there.
Excellent. Well, thank you very much for this talk. It's very much an eye-opener on the challenges of genomic testing, because a lot of people believe, well, why don't we have it here right now? There has to be some reason or something else, but it's very interesting to break it down, especially by province. You mentioned, though, that in the Ontario government, for instance, their rating might be higher in a future survey because they've taken these steps. And I was wondering, based on that, could we expect an update on these grades anytime soon in the future, or the near future, the far future, or is that even being looked at?
Well, I think there's general consensus that it's a bit unfair to come out with a progress report and then not actually monitor progress. So I think the plan is to monitor progress. I have talked with laboratory leaders. I mean, everybody knows that healthcare, the organization of healthcare services and policy change doesn't happen fast enough. It's always glacial pace. On the other hand, it's happening. So, I think the general consensus is we should probably wait 18 to 24 months before we take another snapshot. That might seem very long to some people, but I think in terms of policymakers and providing constructive feedback, that's probably a reasonable time frame. So you might see something in 2025, let's say.
2025. Okay. Well, I will not keep it as a concrete timeline, but that's definitely something to look forward to. Now, we have a couple of questions. There's one more that I wanted to get to, but if you have a question, don't hesitate to put it into the questions box at the bottom. You mentioned briefly that, for instance, the new funding on rare diseases that we have covered, and we've actually did a webinar on as well, that can help with this new genetic testing and help hopefully get some more initiatives off the ground. My question is there anything that you see in the future where the provinces and other organizations can access more funding to widely implement genetic testing in the future?
Do I see any opportunities beyond the rare disease?
Yes, or do you see anything on the horizon that could mean that more people might get access to this kind of testing?
Well, I mean, as I said, I mean, provinces are working on this. It's not ignored. And in some provinces, it's actually part of ministerial mandate letters, and it's considered a priority to get either laboratory services or genetic testing, which is sort of becoming a more significant pressure point, get that shored up. So, but different provinces are having to work on different things. And so, and some are not prepared. Some are very prepared for some things and not prepared for the other. For example, in BC, they had the foresight to move necessary money for genetic testing into the cancer chemotherapy or systemic therapy budget. So meaning that when it's time to release money for a new drug, they actually have the money for the test that's required for the drug. Not all provinces have that. And so that's one example, but that's great. But then that's for oncology drugs. So what happens if we need a new test for a psychiatric drug? Well, they don't have that sorted out yet. So I think, there has to be a health systems thinking and a broader health systems thinking that's put into place around the need and use of these tests. And I get that. I get that for some provinces, they can let perfect be the enemy of the good. I mean, they probably see it as a very big and daunting thing. But in terms of other opportunities, look, these tests are becoming increasingly less costly on a per test, per patient basis. So that's going to create opportunities. The laboratory leaders are becoming increasingly motivated as they're all becoming pressured and have the same pressure points, motivated to coordinate cross-provincially, and there has been increasing activity there. There have been a lot of sort of pilot projects around validating new tests cross-provincially. There's a lot more awareness that some kind of pan-Canadian implementation lab would be a good idea. CADTH has received money through this RARE to look at RARE, and that might provide them with opportunities. They certainly also have on their list of things to do, looking at what they can do about genetic tests, and have had some cross-provincial meetings about that. So there may be opportunities for them to support the sort of appropriate evaluation or implementation of tests, or even support real-world evidence activities around testing. So those are some of the opportunities. It's going to be up to individual provinces, maybe through the rare disease strategy, to think about what they want to do. Beyond that, they're going to have to be using their own funds to think about how to shore up or create these single service organizations like Alberta and Quebec have, which are, become very, 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 very good ideas in terms of creating a lot of the necessary conditions needed to be ready for this.
Excellent. Rosalind asked, what is the difference between WES and regular NGS tests where only results for a set of genes are provided?
Yeah, I mean, NGS test refers to a whole platform that can do, I think, a whole range of things, but mostly we're usually with NGS testing, I think we're typically talking about looking at a couple of, or a panel of different mutations, whereas this whole exome sequencing is looking at a broader swath of DNA, not just looking for these individual mutations, but looking for, and again, I'm not a laboratory leader, but looking for, it's processing much more DNA where you can get much richer information. And then of course the ultimate is, whole genome sequencing. Now, I do think that these are all still done using next generation sequencing technology. So I think NGS can refer to the type of technology that does this. But typically when we're talking about NGS tests, I think we're often just talking about a panel where we're looking at for 3 or 5 mutations, specific mutations. And that whole thing about looking for the specific mutations, I think if you're a geneticist, the whole exome can tell you other things that you might miss if you're looking for specific mutations. So it could be valuable to look for whole exomes, and it certainly seems to be in the realm of screening for a newborn disease. And even comprehensive genomic profiling is being used in newborn disease screening.
So apologies, but Warren asked, if a genomic test is done for advanced prostate cancer, what treatments are used and are they effective?
That's a big question. I can tell you currently, I don't know that currently there are a lot of tests, but there are increasingly going to be. I can tell you that. I do a lot of work with global multinational companies on pipeline. Prostate cancer is going to change quite a bit in the next several years. There are a lot of new therapies around the corner, and some of these are going to require genetic testing. In some cases, they're going to require, there is one large multinational company working on a test where they requires not just one test, but a bunch of tests that go into a kind of algorithm to decide whether or not a person might benefit from a certain type of therapy. So yeah, I can't comment on specifics. CADTH does have on its website, if you Google CADTH provisional funding algorithm prostate, you can see the types of things that are currently being funded in Canada, and then the things that are just around the corner. But you won't have an eye on the things that are coming in a few years. It's going to be madness. There's a lot of, I mean, it's great for prostate cancer patients. There's going to be a lot going on in that area, and there are going to be genetic tests involved. Oh, I see
Similar
that Canada
question.
doesn't have a prostate provisional funding algorithm. I'm sorry, now that I look, but I'm sure they will shortly because it's going to be a very busy area quite shortly.
Joseph asks another question, a similar vein. I live in BC and have prostate cancer. Genomic tests are available but not covered. What are the prospects of getting this $3,500 test covered by BC Health Services? Is routinely used in the US to make critical care decisions?
Well, I think what you're seeing increasingly is, yeah, there are always compassionate use and exceptional access provisions for the use of these tests. You know, what's your chance of getting it covered? I don't know. It depends on your context. If there's solid evidence and they're being used elsewhere and there's really good evidence that it could make a difference in terms of your care, I think that's how they're judging whether or not they want to pay for things. However, and it may not just be that other people are doing it. It has to, you know, they do look for evidence of what's the difference going to be if you do get this test. Currently, unfortunately, most healthcare systems don't see paying for tests that qualify you for trials as part of their business, as part of their remit, as part of their business, and that is very unfortunate because of the value that healthcare clinical trials actually bring to patients, and oncologists certainly would say that for the most part. But this is an old-fashioned idea that healthcare systems shouldn't pay for investigational things. And so by paying for tests that get you into trials, somehow they've crossed over into this realm of research that they don't want to be into. But I think we all know that the future is about learning healthcare systems, and that making artificial distinctions between investigation and healthcare is probably a bit passé. So that's all I can tell you for now, but it'll depend on the evidence.
Mm-hmm. Now, just quickly, Helen, that we will have the slides on our end as well, if the QR code doesn't work for you guys. And as for the peer-reviewed article, Don, if you can send it my way as well, if you don't mind having it linked, we can have that on our website as well for the future. Warren, can knowledge of defective genes actually cure cancers?
Like, knowledge of defective genes cure, that's a big loaded question. Cure is a big loaded word. I've written a paper about what is the value of a cure and what do we mean by cure. It's very interesting, right? In most cancers, tumors, solid tumors, oncologists will say, well, if you've been clear of cancer for 5 years, we consider you cured. And that's because for the most part, we don't see a lot of recurrence of cancer after that time. But there are situations like, and you know, a very good example is melanoma, where we can, through doing testing and identifying that your cancer has a certain type of molecular basis of disease, that it has certain mutations, you may qualify for drugs that actually can essentially cure what at one time was a very, very tragic disease. And now these testing and these new treatments actually offer considerable hope, where we have people who have lived with advanced melanoma for 10 years, for example. And then we're starting to see the same thing in other cancers like non-small cell lung. We're seeing exciting developments even in things like endometrial cancer, which seem to, new tests and new drugs are going to have a dramatic impact.
And Warren again with another one, is genomic testing a part of immunology cancer treatments?
Well, it is going to be, if you mean like immune checkpoint inhibitors currently don't actually require genetic testing. Sometimes they require what's called an immunohistochemical test or immunoassay, which is a very inexpensive test and very relatively uncomplicated test, just to see if you might qualify for this immune checkpoint. In some cases, they'll give you immune checkpoint inhibitors without testing in certain types of cancers. But we're still, again, these new immune checkpoint inhibitors aren't necessarily dependent on genetic tests, but there are a number of other drugs that are going to require some level of genetic testing. Anything from, and it could be cell therapies and gene therapies. It could be a number of things.
All right, one more question actually from me. You say that you're doing a lot of other research in a lot of other fields. Is there anything that you would like to share to expand on what you're working on to kind of get a better idea of what exactly, what else you do in the healthcare field, if you can talk about it?
Yeah, well, I mean, I think, you know, for an individual patient, being part of a healthcare system is a pretty daunting experience. I can imagine, you know, we still have, for example, for cancer patients entering a cancer system, there are still questions of how does this even work? I still am learning every day about, for example, I just started asking myself the question of, if I need oral cancer drugs in the province of Ontario, how much would I be on the hook for? It's not a question I ever asked myself. And of course, if I lived in Alberta, I would be on the hook for a much different amount, given the way that different provinces are covering. I guess what I'm very interested in is are in issues of equity. I think we do need to have a health system. We unfortunately have this structure of our health system where we've given individual provinces the remit to do things individually, and yet they're supposed to be delivering care in an equitable way. So I'm interested in how can we make that happen. And so doing this type of research is meant to kind of help us think about how can we get everybody there. But there are opportunities for provinces to work together to do things more equitably. I'm also just very interested in engagement. I think we came from a time where it was okay for health systems to make really important decisions without talking or engaging with anyone, and just behind a closed door. I think those days are kind of over. I think we need to see a lot more engagement and transparency. I look forward to a day where the kinds of meetings where I've attended, where I sat with a bunch of experts and talked about why a new therapy, for example, what its merits were, what its drawbacks were, what it meant to have additional costs, where all of those discussions are open. It's astounding to me that a patient has no visibility to how decisions that are affecting patients' lives are being made all the time. So I do hope to do more work in the realm of making HTA to motivate and progress in the world of HTA. I think the evaluation part is never going to go away. We have to think about modernizing that, and we have to think about how we engage with external stakeholders through doing that. And so I think that to me is going to be very interesting if we can improve the way that we engage and evaluate things going forward. So I hope to get much more also involved with patient education, which I've done in the past, because there's no sense complaining about a dirty poker game once you're already in it. I think we need to recognize the problems with the current system, and patients are going to be the key motivator to all that. But if they don't know what they don't know, how are they going to change? So, I'm very interested in making sure that groups like this are going to be very well informed about the deficiencies and the opportunities in improving how new technology gets into the system in the future.
Mm-hmm. We have actually a couple more questions, but we'll soon wrap it up. Christine asked, does genetic testing offer better choices on which systemic therapies would best work for each particular patient, kidney cancer in particular?
Yeah, it all depends. I mean, in some cancers, genetic testing plays almost no role. In other cancers, it's playing an increasingly very important role. So if you come from a colorectal cancer community, you'll quickly discover that genetic testing is a very important aspect of that. Similarly with some kinds of obstetric cancers, some types of lung cancer. But there are cancers, you mentioned kidney cancer. Off the top of my head, I can't quite recall if it actually is playing a big role yet. but it may do so. I think in all cases, certainly pharmaceutical companies are always looking at biomarkers and ways to identify the patients who are going to benefit the most or be harmed the least. But and in many cases, through discovering the genetic basis of illness, they're looking at genetic biomarkers. Not always. They're still going to, look, if there's any way we can identify patients and it goes beyond genetics, if it's a better way, the example I always cite is knowing how much a patient has smoked for certain types of lung cancer is actually more important than knowing their genetic information. And so that's not a genetic piece of information, but that's a piece of information.
And then finally for Louise, which of the challenges you mentioned must be prioritized? For instance, provincial agreement to budget, HTA submissions, what should be kind of the priority for people to focus on to get it better implemented?
Well, I do have a personal bias. I mean, years ago, I was part of this Naylor Commission report on innovation and technology. I was asked to look at the value of innovation and technology, including changing the way we organize care, changing the way we, commercial innovation like vaccines, anything that we think about in terms of technology that can help healthcare. Information technology and investments in information technology, for reasons that are not hard to imagine, are the single most important investments in healthcare. They empower patients. They allow us to, they allow patients to then have better care navigation, information, education. They empower care providers, having very good, they allow us to measure things and measure what is valuable. It allows communication to happen. It stops duplication of service, on and on and on. So any investments that we can make into making informatics, accessible, easy, shareable, that's where they have to make the investment. And part of me thinks people should stop what they're doing. I mean, it's that, and then of course, if we want to improve the health of Canadians in the future, it starts with early intervention and education and early childhood programs and the lights, all the stuff you don't think about, which is giving people a healthy head start. So that's how we need to go. Unfortunately, those two things always get sidelined, but that's where all the money is. That's where all the value is.
Yeah. All right, well, we'll put a stopper on there. Thank you once again, Don, for this presentation. It's extremely eye-opening, and hope to have you back again, hopefully maybe in a couple of years, whenever we're going to have an update on where everyone is on this, on where they are in genomic testing. So thank you very much for that presentation.
Thank you for having me. And like I said, don't hesitate, anyone, to reach out if you have any further questions.
Mm-hmm. Now, this is one in a series of webinars that we are putting on this fall. Our next one is actually happening next week. So to stay in a loop about webinars, check our website or check your email for our e-blast. If you're not seeing the email in your inbox, check your spam folder or any of the other updates or other folders that other web mail providers have, because sometimes it might be in there and it might not be in your main inbox. And make sure you also subscribe to our newsletter on our website to not miss what we're doing here at CCSN. And all the webinars, including this one, will be available on survivornet.ca/webinars, or you can check them out on CCSN's YouTube channel. So with that, I'd like to say good afternoon to everyone, and I hope you have a good rest of your day.